Hi everyone. Now we are going to discuss a topic which is IUGR, intrauterine growth restriction, which is also called as FGR, fetal growth restriction. Now this is an important topic for all the central institute exams like INI set, and it is also important for NEET PG. But as far as the FMG exams are concerned, or as far as undergraduate level is concerned, not many questions are asked to you on IUGR. What am I going to discuss? I'm going to discuss the causes of IUGR, the definition of IUGR. I'm going to compare with you symmetrical and asymmetrical IUGR, the management of IUGR, time of delivery, and the ponderal index. So coming to the first thing, what is the definition of IUGR? See, definition of IUGR is if estimated fetal weight, it is less than 10 percentile, that is what is called as IUGR. Now, if the estimated fetal weight is around 10 percentile, so if it is around 10 percentile, that is what is called as a mild IUGR, right? But if it is less than if it is between 3 to 10 percentile, then that is what is called as a moderate IUGR. And if the estimated fetal weight is less than 3 percentile, that is a severe IUGR. The other definition for IUGR, other than if estimated fetal weight, is based on abdominal circumference. If abdominal circumference becomes less than 10 percentile, then also we say that there is IUGR. Now, the causes of IUGR can be a result of fetal causes, some fetal effects problems. It could be a result of maternal problems, or it could be a result of the placental problems. Now, the fetal causes which lead to IUGR are if there is fetal intrauterine infection, or if there are congenital anomalies or chromosomal anomalies, or multifetal pregnancy. So the four very important common causes are the chromosomal anomalies, congenital anomalies, if there are intrauterine infections, and multifetal pregnancy. As far as the congenital anomalies are concerned, if I ask you what all congenital anomalies commonly can lead to IUGR, then please remember abdominal wall defects like omphalocele and gastroschisis, then skeletal dysplasias and diaphragmatic hernias. These are common congenital anomalies which can lead to IUGR. Similarly, if I ask you what are the common chromosomal anomalies which can lead to IUGR. So the common chromosomal anomalies which can lead to IUGR are, please write down. So the common chromosomal anomalies which lead to IUGR are triploidy and trisomy. Triploidy and trisomy 18 specifically. These are the ones which lead to IUGR. In trisomy 18, you have to remember that there is IUGR plus polyhydramnios. See, normally IUGR is associated with oligohydramnios. When a fetus is going to get less blood, then it is going to send less blood to the kidneys, and because there will be decreased renal blood flow, so urine output in the fetus will decrease, and that leads to oligohydramnios. But trisomy 18 is one condition in which you get polyhydramnios and you get IUGR, right? Now, what are the maternal causes which lead to IUGR? So medical problems and obstetrical problems in the mother can lead to IUGR. Then if there is teratogenic exposure to the mother, that can lead to IUGR. If mother has low BMI and there is poor weight gain in pregnancy, that can lead to IUGR. Please remember a very important thing, that high altitude, if the pregnant female is living in a high altitude, even that can lead to IUGR. Then short interpregnancy intervals and increased maternal age. These are the maternal causes which can lead to IUGR, right? So I don't think so any of these needs any explanation. See, for topics like IUGR, what I want is that first you should be well versed with PIH. You should also have watched the lecture on OBS radio integration. Then this video on IUGR becomes relatively easy for you to understand, right? Now, what are the placental causes which can lead to IUGR? I'm sure all of you know that. We did it in PIH also, that uteroplacental insufficiency leads to IUGR. Then when I took antiphospholipid antibody syndrome, I told you antiphospholipid antibody syndrome can lead to IUGR. Also placental anomalies. Placental anomalies like single umbilical artery, velamentous insertion of the cord, circumvallate placenta, all these can lead to IUGR. Now, a very important concept which you have to understand is when fetal causes lead to IUGR, it leads to symmetrical IUGR, which happens early in pregnancy. So if you are getting symmetrical IUGR generally happens in early in pregnancy. And when I say early in pregnancy, it means at less than 32 weeks. Right? So fetal causes like chromosomal anomalies, congenital anomalies, infections, all of them, they lead to symmetrical IUGR, and symmetrical IUGR has an early onset. In comparison to placental causes and maternal causes, placental causes and maternal causes, they lead to asymmetrical IUGR, and asymmetrical IUGR has late onset, right? So now let's talk about what is symmetrical IUGR and what is asymmetrical IUGR. First of all, let's talk about which one is more common. So remember, asymmetrical IUGR is more common than symmetrical IUGR. Amongst all the cases of IUGR which happen, symmetrical IUGR, it represents only 20 to 30% of the cases. Now, as the name suggests, in symmetrical IUGR, what is going to happen? All the organs, whether it is the body, whether it is the head, whether it is the length of the baby, all of them will be affected proportionately. Right? Now, why is symmetrical IUGR happening? As I told you, fetal causes like chromosomal anomalies or infections or congenital anomalies, all of them are the causes for symmetrical IUGR. Whenever there is an infection in early intrauterine pregnancy or a chromosomal cause, or if there is a congenital anomalies, it leads to decrease in the nutrient supply to the fetus. There is decrease in nutrient supply to the fetus, and this decrease in nutrient supply to the fetus affects all the organs symmetrically, right? So the baby's head will also be small, length will also be small, everything will be proportionately small. Now, if I ask you that I have a patient in whom there is symmetrical IUGR, what all investigations would you like to offer? So just now I told you symmetrical IUGR is happening because of fetal causes like chromosomal anomaly. So because it is due to chromosomal anomaly, I'm going to order a karyotyping. Number 2, it can be due to congenital anomalies, right? So because it can be due to congenital anomalies, I'm going to do a targeted scan. Right, that is level 2 scan. Then it can be due to infections, so I'm going to get a torch test done. So this means that these are the investigations which you do whenever you have a fetus with symmetrical IUGR, whenever there is symmetrical growth restriction, right? In contrast to this, if I ask you, what are the features of asymmetrical IUGR? So in asymmetrical IUGR, see, the first thing is it is late in onset. Right? It does not happen early in pregnancy. And when I say it happens late in onset, it happens at more than equal to 32 weeks of pregnancy. Right? That's number 1 point. Number 2 point about asymmetrical IUGR is that this is more common of the two. Between symmetrical and asymmetrical IUGR, it's the asymmetrical IUGR which accounts for 70 to 80% cases. Now, in this case, what happens is that the head circumference is preserved, length is somewhat affected, right? So head circumference is absolutely preserved, length is somewhat affected, but weight is compromised to the maximum degree. Right? So birth weight is decreased to the maximum degree, length is affected but not that much, and head circumference is preserved. So as you can see, all the organs are not affected proportionately, right? So in this case, when I'm going to see a baby will be born with IUGR, the head of the baby will be normal as compared to the size of trunk and extremities. Right? So in comparison to the size of extremities and trunk, the head of the baby is going to be normal in size, right? So abnormal growth, typically it begins in the late second or third trimester, and it results from reduction in fetal nutrients that are going to limit the glycogen and fat storage. So now there will be a reduction in fetal nutrients, and these fetal nutrients are going to cause a reduction in glycogen storage and fat storage. But on the other hand, they will allow continued brain growth. So that is what is called as the brain sparing effect. So what happens in asymmetrical IUGR? In asymmetrical IUGR, whenever there is decreased nutrient supply or decreased blood flow in asymmetrical IUGR, whenever there is decreased blood flow, what is going to happen? Because of this decreased blood flow, what fetus is going to do? Fetus, it collects blood from all the peripheral organs. It collects blood from all the peripheral organs, right, and sends it to the brain. This is what is called as the brain sparing effect. And because of this brain sparing effect, the head circumference remains normal, right? So there is this brain sparing effect. So because there is decreased blood supply, so obviously if there is decreased blood supply, what is going to happen? There will be less glycogen and there will be less fat. And when there will be less blood supply, less nutrient, so glycogen and fat storage will be affected. But what is not going to be affected? The brain growth will not be affected. The head circumference will not be affected because of the brain sparing effect, right? And since 70 to 80% cases of IUGR are asymmetrical IUGR, that is why whenever we talk about IUGR, we just say that yes, there is a brain sparing effect. But you should understand that this brain sparing effect is seen in asymmetrical IUGR. It is generally not seen in symmetrical IUGR. You're not going to get any brain sparing effect in symmetrical IUGR, right? Now, if I ask you that asymmetrical, just now I told you asymmetrical IUGR is happening due to placental causes and it is happening due to maternal causes. So does it make any sense that if I have a pregnant female in whom IUGR is detected at 36 weeks and the fetus has got asymmetrical IUGR, does it make any sense to do genetic testing? Does it make any sense to do karyotyping? No, because chromosomal anomalies, they lead to early onset IUGR. In other words, they lead to symmetrical IUGR. So now if I ask you, what are the indications of karyotyping in IUGR? So as I was telling you, early onset, the definition for early onset is any IUGR which is happening at less than 32 weeks. Now, if IUGR is happening much before than that, so if IUGR is happening at less than 24 weeks, then definitely that is an indication for doing genetic testing. Number two, I told you, in case of trisomy 18, there is polyhydramnios along with IUGR. Normally, you get oligohydramnios. So suppose you are getting like this, that there is a case of IUGR and polyhydramnios, then again, that's an indication for doing genetic testing. Number three, if you have got congenital malformations present in the fetus. So if on targeted scan you get fetal malformations, again that's an indication for doing genetic testing. Or suppose on ultrasound, when you did an ultrasound, the targeted scan, you are getting soft tissue markers for aneuploidy. So if you are getting soft tissue markers for aneuploidy, then that is also an indication for doing karyotyping or genetic testing. So these are the indications for doing karyotyping or genetic testing in patients with IUGR, right? Now, there is one term, constitutionally small babies, and there is this other term, IUGR. In constitutionally small babies also, the estimated fetal weight is less than 10 percentile. So how am I going to know whether I am dealing with a constitutionally small baby or whether I am dealing with IUGR in the antenatal period? So if you are dealing with IUGR, definitely the weight of the baby will be less than 10 percentile, but associated with IUGR, you are also going to find oligohydramnios or abnormal Doppler studies. Suppose if you are getting estimated fetal weight between 5 to 10 percentile, there is no oligohydramnios, there are no Doppler abnormalities, and even the mother is appearing small to you. You are seeing the patient in front of you, the mother is appearing small to you, and when you do an abdominal circumference, the abdominal circumference may be more than 10 percentile, right? So then you come to a conclusion of constitutionally small babies. So in case of IUGR, along with the estimated fetal weight being less than 10 percentile, you're going to get oligohydramnios or you're going to get Doppler studies abnormal. But in constitutionally small babies, nothing of that sort happens. The estimated fetal weight is between 5 to 10 percentile, and the mother also appears small. There is no oligohydramnios, no abnormalities of Doppler study, and abdominal circumference may be more than equal to 10 percentile. Clear to all of you? Yes? Okay. Now, how do you do a screening for IUGR? See, this is not like we are telling someone that I'm doing a screening for IUGR. I have told you in antenatal patients, I have told you that whenever they come to you for their antenatal visits, from say third trimester onwards, you have to measure their symphysiofundal height. Now, when you are measuring the symphysiofundal height, normally what happens is that the symphysiofundal height, it corresponds to the weeks of gestation. So, symphysiofundal height in centimeters, it corresponds to the weeks of gestation. Now, suppose there is a discrepancy of 3 weeks. In other words, the symphysiofundal height is coming less than 3 centimeters than the gestational age. So, for example, the gestational age of the patient is 36 weeks and you are getting symphysiofundal height as 32 weeks, right? Then that rings a bell. That tells me that this patient might be having IUGR or there could be discordant growth. So in that case, what I'm going to do next, I'm going to do an ultrasound and I'm going to check the estimated fetal weight and I'm also going to check the amniotic fluid volume. Right? So if some symphysiofundal height, it is coming less than 3 centimeters from the gestational age, that is the first suspicion of IUGR. Then, as I told you, in a normal pregnancy also we go for growth scans. And when are the growth scans done? Growth scan is done at 32 week and 36 weeks. So when you do growth scan and you see that yes, estimated fetal weight has come out to be less than 10 percentile, then you come to know that yes, you are dealing with IUGR. So based on symphysiofundal height and based on estimated fetal weight on growth scans, we can come to know that yes, we are dealing with a case of IUGR. Now, if on growth scan, either the estimated fetal weight may come less than 10 percentile or abdominal circumference may come less than 10 percentile, either of these two things when they come, then I make a diagnosis of IUGR. Now, once I have made a diagnosis of IUGR that yes, estimated fetal weight is less than 10 percentile or abdominal circumference of the fetus is less than 10 percentile. Now, once I have made a diagnosis of IUGR, I'm going to check the other biometric measurements also. I'm going to check the abdominal circumference, the head circumference, the femur length. And then I am going to see certain ratios. The first ratio which you have to see is head circumference is to abdominal circumference. See, normally what happens in pregnancy? Normally in pregnancy, the increase in abdominal circumference will be more than the increase in head circumference. Right? So as pregnancy is going to advance, what is going to happen? This ratio is going to decrease. Now imagine a case of asymmetrical IUGR. In a case of asymmetrical IUGR, what is going to happen? In a case of asymmetrical IUGR, just now I told you that there is a brain sparing effect. So if there is a brain sparing effect, the head circumference is going to remain normal. What is going to happen to abdominal circumference? Abdominal circumference will be decreased. So the numerator is remaining normal, the denominator is decreasing. So what is going to happen to this ratio? This ratio will be increased. So if head circumference is to abdominal circumference, this ratio becomes more than 2 standard deviations. Then that indicates you are dealing with asymmetrical IUGR. So have you understood this much? That in asymmetrical IUGR, head circumference has to be preserved and abdominal circumference will decrease. Right? So because abdominal circumference, that is the denominator, decreases, so the ratio increases. But tell me, can you get an increase in this ratio in any other condition also? Yes. Suppose there is a case of macrosomia. Now, in a case of macrosomia, the head circumference will be increased. So if head circumference is increased, the ratio will increase. right? So whenever the ratio is increased, it does not always mean asymmetrical IUGR. It could mean macrosomia. It could also mean increase in intracranial pressure. Clear to all of you? Now, the second ratio which I'm going to see is femur length upon abdominal circumference. And as I told you just now, that in case of asymmetrical IUGR, head circumference is not affected, femur length is less affected, and abdominal circumference is maximally affected. Right? So, the abdominal circumference will decrease, and because the abdominal circumference will decrease, this ratio will increase. So, femur length upon abdominal circumference ratio is also increased in case of asymmetrical IUGR. Right? Now, so these are the investigations. So first of all, I came to the diagnosis of IUGR based on symphysiofundal height. Once I saw symphysiofundal height was less, then I did ultrasound, and also I can do this also IUGR can be detected during routine growth scans. Once I make a diagnosis of IUGR, I'm going to see other biometric ratios. And now if this is early onset IUGR, so if this is early onset IUGR, that means it is happening at less than 32 weeks. What all tests am I going to do? If this IUGR happened at less than 32 weeks, I'm going to go for a level 2 scan, for karyotyping, and for torch testing. Right? Now, if this is a late onset IUGR, in late onset IUGR, one of the very common etiologies is uteroplacental insufficiency. Right? So now you have done PIH, and so now you are going to tell me which is the most important vessel or the first vessel to show changes in uteroplacental insufficiency. So the first vessel which shows changes whenever there is uteroplacental insufficiency is umbilical artery. Right? So I have to do umbilical artery Doppler. Right? So the first vessel which is going to show changes in a patient of PIH or uteroplacental insufficiency is umbilical artery. Now, what is the change which you get in umbilical artery Doppler? I have told you in the previous video that SD ratio in umbilical artery Doppler, it is normally less than 3. So normally the SD ratio is less than 3. Right? But if this SD ratio becomes more than equal to 3, what does that mean? If SD ratio increases, this means that during diastole, less blood is going in the vessels, and that is happening because of the PIH. So then I come to know that yes, this is a case of uteroplacental insufficiency. So the first vessel which undergoes changes, which is going to show you changes in uteroplacental insufficiency, is the umbilical artery. Normally in umbilical artery, if you see SD ratio, so normally this SD ratio, it decreases as the pregnancy advances because blood flow during diastole is going to increase as pregnancy is going to advance. But when there is PIH or when there is uteroplacental insufficiency, the blood flow during diastole is less into the umbilical artery, and so this ratio is going to increase. So if SD ratio becomes more than equal to 3, you come to know that yes, you are dealing with a case of uteroplacental insufficiency. Clear? Now, in uteroplacental insufficiency, what happens? As I told you, in uteroplacental insufficiency, it leads to asymmetrical IUGR. Right? Now, in uteroplacental insufficiency, what is going to happen? There will be decreased blood supply to the fetus. And what is fetus going to do? It is going to redistribute the blood to the brain. And because it is going to redistribute the blood to the brain, that is called as the brain sparing effect. So, if I ask you that there is a case of uteroplacental insufficiency, so early in the disease, in early cases, should you go for middle cerebral artery Doppler? No, because in early uteroplacental insufficiency, because of the brain sparing effect, the middle cerebral artery Doppler will be normal. So the first vessel which you have to see is umbilical artery. Middle cerebral artery the Doppler is not going to show you any changes because in asymmetrical IUGR, there is a brain sparing effect. So early in the course of uteroplacental insufficiency, there is no use of getting middle cerebral artery Doppler done. It is later on that as uteroplacental insufficiency is going to progress, the middle cerebral arteries resistance is going to decrease further. So now fetus will try to send more blood to the brain and the resistance of the middle cerebral artery will decrease. So the SD ratio will decrease or the end diastolic velocity will increase, right? Now, as uteroplacental insufficiency advances, what happens? Now fetus is trying desperately to take the blood to the brain. And because maximum blood has to reach the brain will have to relax the middle cerebral artery a little. And because the brain is going to relax the middle cerebral artery a little, so the amount of blood flow during diastole will increase. So if amount of blood flow during diastole will increase, SD ratio will decrease and end diastolic velocity will increase. So in case of IUGR, you do get changes in middle cerebral artery Doppler, which are exactly the opposite of the changes which you were getting in umbilical artery Doppler. But then in umbilical artery Doppler, the changes come very early in the disease, right? Whereas changes in middle cerebral artery, they are detected later in the course of the disease. Then, the last vessel which is going to show reversal of end diastolic flow is the ductus venosus. And whenever you get reversal of flow in ductus venosus, the last vessel to be affected will be ductus venosus. And whenever you see that there is a reversal of flow in ductus venosus, it indicates impending death. First vessel is umbilical artery. Then, yes, you should know the changes which are happening in middle cerebral artery Doppler. And the last vessel is ductus venosus. So till now, what have I told you? I have told you that once you've made a diagnosis of IUGR, you should try to see whether you are dealing with a case of symmetrical IUGR or asymmetrical IUGR, and you should also try to find the cause. And to try, in order to find the cause, I told you the investigations which you have to do in early onset IUGR and the investigation which you have to do in late onset IUGR. Now, let's talk about the management of IUGR. Now, in the management of IUGR, there are three things which you have to always include. You have to do a fetal monitoring, and this fetal monitoring is done by ultrasound for the expected fetal weight. And ultrasound for expected fetal weight in a patient of IUGR, it should be done after every 3 weeks. Then you have to go for non-stress test and weekly evaluation of amniotic fluid, weekly evaluation of umbilical artery Doppler, and fetal monitoring is done by non-stress test. How often you have to do a non-stress test? Just now I let you know. See, this is the management which I am going to tell you in IUGR. It is based on Williams 26th edition, page 829. There is a flow chart which is given for management of IUGR, and that flow chart includes everything. Now, the same flow chart I am going to tell you, and everything related to management of IUGR will be clear with the help of this flow chart. It's a very important flow chart in the entire video on IUGR. If you ask me, ma'am, what is one thing which is very important? This flow chart is one thing which is very important. So Williams 26th edition says that whenever you suspect fetal growth restriction, you should always go for a detailed ultrasound, umbilical artery Doppler, and you should offer genetic testing. Genetic testing, it should be offered if you are getting early onset IUGR, or if there are anatomical abnormalities, or if there is polyhydramnios, right? So if there are anatomical abnormalities, then the chances of chromosomal abnormalities are high. If there is polyhydramnios associated with IUGR, then there are chances of chromosomal abnormalities. And if there is early onset fetal growth restriction, then there are chances of chromosomal anomalies. That is why whenever you are getting any of these three things, you should offer a genetic testing. Then you can go for maternal serum or amniotic fluid testing for torch infection. Now, this particular box is telling you that how you are going to determine the cause of the growth restriction, the IUGR. Then comes, how are you now going to further manage this? Now, whenever I come to know that yes, there is fetal growth restriction, now I am going to follow up such pregnancies with serial fetal growth assessments. The serial fetal growth assessment has to be done with an ultrasound, which you have to do every 3 weekly. Then umbilical artery Doppler, which you are going to do weekly, and amniotic fluid assessment, which you are going to do weekly, and fetal surveillance with NST or biophysical profile. Now, how often we are going to do NST or biophysical profile, that totally depends upon what is the umbilical artery Doppler showing to me. If I am getting a normal umbilical artery Doppler, that is situation A. So A means that now I did an umbilical artery Doppler and that is absolutely normal in this pregnancy where the fetus has growth restriction. Then a situation B could be that the umbilical artery Doppler is showing you absent end diastolic flow. So if you remember the video on radio obs integration, there I told you that this condition over here where during the diastole you are not seeing any blood flow, that indicates absent end diastolic flow in umbilical artery. And this situation over here, this Doppler which is shown over here where you are getting reversed end diastolic flow, that constitutes the third condition. So when I do in a pregnancy where there is fetal growth restriction, where there is IUGR, when I do umbilical artery Doppler, I categorize my patient into 3 categories. First category is where I am getting a normal umbilical artery Doppler. Second category is where I'm getting absent end diastolic flow. And third category is where I'm getting reverse end diastolic flow. Now, all these 3 categories, now I'm going to tell you in detail that how are you going to do further management and at what time are you going to deliver the patients in any of these categories. Now, first category is when you are getting a normal umbilical artery Doppler. Now, whenever you get a normal umbilical artery Doppler and there is IUGR, again, you have to do these things. You have to go for fetal assessment through ultrasound, the growth assessment through ultrasound. You have to do NST, you have to do biophysical profile, you have to repeat Doppler, and you also have to go for amniotic fluid assessment. But how often? This depends upon what kind of umbilical artery Doppler you were getting. Now, in this situation where you are getting a normal umbilical artery Doppler, you are going to repeat the Doppler weekly, you are going to do NST or biophysical profile weekly, and you are going to assess the fetal growth 3 weekly. Now, if everything remains normal, if the Doppler remains normal, NST remains normal, and fetal growth just is showing you IUGR, now depending upon how much growth restriction is there, I'm going to plan the time of delivery. If the expected fetal weight is between 3 to 9 percentile, then the time of delivery is 38 to 39 weeks. But if expected fetal weight or the estimated fetal weight is less than 3 percentile, then the delivery should be timed at 37 weeks, right? The other thing which you have to note is at any point of time, if you are getting oligohydramnios, then if oligohydramnios is present, then the time of delivery becomes between 36 weeks to 37 weeks. Now, as far as the mode of delivery is concerned, as long as fetal heart rate pattern remains normal, the preferred mode of delivery is vaginal delivery. But what you have to remember is that during labor, some of these fetuses, they do not tolerate labor well, especially if oligohydramnios is present. So you should be prepared for cesarean section as well, right? This was first category where umbilical artery Doppler showed was normal. Now comes second category where umbilical artery Doppler shows you absent end diastolic flow. Now, whenever umbilical artery Doppler is showing you absent end diastolic flow, you should consider this patient for hospitalization. You should give corticosteroids for fetal lung maturity. And if your patient is hospitalized, you should do NST once or twice daily. If your patient is not hospitalized, then you should do NST once or twice weekly. The umbilical artery Doppler, it should be done at least 2 to 3 times in a week, and ultrasound for fetal growth assessment should be done every 3 weekly. Now, I will do this and I'm going to deliver the patient between 33 to 34 weeks. Now, this is something new which I'm telling you. Till edition 5, we were saying that if there is absent end diastolic flow, the time of delivery is 34 weeks. Now the new William says that the time of delivery is between 33 to 34 weeks. And this is how you have to follow up a pregnancy where the Doppler is showing you absent end diastolic flow. Now I'm going to tell you how you're going to follow up a pregnancy when the Doppler shows reversed end diastolic flow. See, everything what I told you in absent end diastolic flow falls true for the reversed end diastolic flow as well. So everything is same for reversed end diastolic flow also. The only thing is over here I'm saying consider hospitalization. There you have to hospitalize the patient. And over here we are saying that the time of delivery is 33 to 34 weeks. There we say that the time of delivery should be between 30 to 32 weeks. Rest everything is same, that you have to do NST 1 to 2 times daily. You have to go for umbilical artery Doppler 2 to 3 times in a week. Then you have to go for fetal growth assessment every 3 weeks and you have to give corticosteroids. So look over here. If there is umbilical artery Doppler is showing you reversed end diastolic flow, you have to do hospitalization. You have to give corticosteroids for fetal lung maturity. NST has to be done 1 to 2 times daily. Umbilical artery Doppler has to be done 2 to 3 times per week. And ultrasound has to be done every 3 weekly, and you're going to deliver the patient between 30 to 32 weeks of pregnancy. Again, the same thing, I'm going to try vaginal delivery, but then again, these fetuses, they do not tolerate vaginal delivery well, and you may have to take them up for cesarean section. Right? Please remember that when you are doing the expectant management, there is no role of nutrient supplementation, there is no role of aspirin, there is no role of heparin, there is no role of oxygen therapy, and no role of antihypertensives. All these things, they do not have any role in IUGR, right? In management of IUGR. Now, does IUGR carry any neonatal risks as well? Yes. Now, the fetuses which have got IUGR, when they are born, at that time, there are increased chances of hypoxia. So, there are increased chances of neonatal hypoxia. And all of you know that whenever there will be hypoxia, fetus is going to release meconium, and that meconium is going to come in amniotic fluid, and then it can swallow that amniotic fluid. So yes, there are chances of meconium aspiration syndrome. Now, this hypoxia is not only happening in the neonatal period, it was also happening in the fetal period. That is why it has led to meconium aspiration syndrome. Apart from that, there are chances of hypoglycemia. Because of hypoxia, erythropoietin is released. So there are chances of polycythemia and hyperviscosity. Now, does IUGR affect the adult life in any way? Yes, that is what is called as Barker's hypothesis. Barker's hypothesis says that adult mortality and morbidity, especially cardiac dysfunction, can be related to the growth restriction which that adult might have had in the intrauterine life. Now, IUGR, it affects the development of the organ, and that is why when such fetuses, when they are born and they grow into adults, they have increased chances of hypertension, atherosclerosis, type 2 diabetes. Right? So, there are things which they may manifest in their adult life, and that is hypertension, atherosclerosis, and type 2 diabetes. And this is what is called as Barker's hypothesis. Now, some other important points which I want to tell you on IUGR, there are certain infections. See, there is a list of infections which can lead to IUGR. Some of the important ones I'm going to tell you here. Rubella infection, cytomegalovirus infection, TB, syphilis, toxoplasma gondii, and congenital malaria are some of the very important infections which can lead to IUGR. And before I end, I want to also tell you something about the ponderal index. Now, weight parameters at birth, they are not a very sensitive index to detect IUGR. But yes, ponderal index is a very useful tool to detect IUGR, particularly in asymmetrical IUGR. Now, what is ponderal index? Ponderal index is the ratio of body weight is to length. Now, this ponderal index, it can be calculated by weight in grams into 100 divided by the length in centimeter cube. Right? So, with normal growth, what happens? Now, when the fetus is growing normally, between 30 to 37 weeks, the ponderal index will gradually increase because weight of the fetus increases more in comparison to the length. And then, so between 30 to 37 weeks, ponderal index increases and then it becomes constant. Now, if ponderal index is less than 10 percentile, that means the fetus is not gaining enough weight, and that means that there is fetal malnutrition. And if ponderal index is less than 3 percentile, then that indicates severe wasting. So you should know what is ponderal index. It is the ratio of body weight is to length. So this is all what you need to know on IUGR. Especially remember the management of IUGR and the flow chart which I have told you towards the end of the lecture. Take care. Bye-bye.